I'm Bill Heald. I came to Basingstoke in the 1970s. There was a total of 3 surgeons to cover everything in those days. We've now got 15 to 20, according to where you draw the line. So things have changed. And one of the biggest and most important things that has changed is that colorectal surgery has become a proper specialty during that intervening period. And one of the biggest steps forward was about 10 years after I started, it began to be apparent to us that liver surgery was an important part of the management of colorectal cancer. And I exercised every seductive skill I could manage to get this man here, Merv Rees, to come and work in little old Basingstoke, because I knew that the liver unit there would flourish under his leadership. And indeed, all these years later, we have one of the biggest referral units, and certainly in our view, the best in the country for dealing with colorectal liver secondaries. So Merv, it's a privilege to have you here. I'm glad you've been here all these years, been a fellow traveller in this disease, which is probably the most rewarding of the cancers, because it's the one that both you and I can cure, and Brendan particularly, can actually cure people of a curative cancer. That's the most important in that sense, perhaps, of all the cancers. And the liver is the most surprising new component of that curability that has emerged during my professional lifetime.
So, Bill, it's a pleasure to be here. I remember when I arrived, I certainly felt seduced at the time, I have to say. And but equally, I was very grateful to you for all the support you scrubbed in for the first 20 livers, do you remember? Yes. Just to keep everybody out of my way.
Probably wasn't anybody else.
I was focused on operating and you were chatting away as ever. But here we are over 30 years on, and I thought we'd set our stall out as to how far we've come, Bill. I think this may surprise you. As you can see here, as of today, we've just passed 3,000 liver resections for colorectal metastases. So I think we can say we know a little bit about it now. Our median blood loss over the 30 years is 270 mils, and the last 10 years we've kept pushing it down, is 210 mils. We very rarely transfuse anybody unless they're anemic. The length of stay is interesting because it was 10 days for 10 or even 15 years, and then we realized actually they are okay, so they can go home. So it's come down ever since, and the last decade is 5 days for major surgery, and during the pandemic we managed to get it down to 3 days, because as soon as we mentioned that the patient was fit enough to go home, woof, they were gone. And it just shows that all the excuses that one normally gets didn't apply. It's major surgery, and you know, it's a bit like climbing mountains or sailing. You have to have respect for the environment, and we certainly do that, because the liver will bite back. But our 90-day, because obviously 30-day mortality is not really representative of what goes on anymore, it is 1% and just under 1% in the last 10 years. So we got quite pleased about that. But if you cast your mind back all those years ago, Bill, you remember I used to go and talk to people, give talks, and everybody was so critical. Nobody believed it would work. They didn't even believe we could do the operation. And they said it's a terrible thing to do to people. So I'll just show a couple of studies we did on quality of life together with Jane Blaisby in Bristol. And I'm proud to say that, you know, we took 250 patients and showed that quality of life was maintained, just a little dip at 3 months, back to normal at 6, and maintained at 12 months. And then the first 100 that made it 5-year survival we redid the analysis with Jane on the same cohort, and actually you can't really read that, but suffice to say that the quality of life was maintained, and there was one big improvement, that at 5 years they're much less anxious, which is, I guess, understandable, but I think sometimes we don't realize quite how anxious our patients are and how much more, we need to be supporting them all the way through.
Can I just take it back, Merv? One of the amazing things, I was Merv's trainee registrar, and it was always obvious to me that it's fascinating that the liver, you can actually cure metastatic disease, because that was the first issue, wasn't it? And of all the metastatic disease that we try and tackle, whether it's lung mets, liver mets, but the liver is amazingly better, isn't it?
Well, if I'm honest, there were two big issues that we had to tackle at the very outset. One, can we do the surgery safely? And, I can show slides in a minute of how that come, where we came from. But the second thing was, will it really work? Yeah, and if I'm honest, Brendan, I didn't really believe it either. Yeah. But, I was a sort of young, headstrong, ambitious surgeon, and it seemed like a good idea. And then you started seeing these people year after year. And I'm starting to think, goodness me, it does work. Yep. Not in everybody, but surprisingly in so many areas. And before we perhaps go into the detail, we learn from our patients, and it was a local patient that taught me so much. We did, because I was doing anterior resections in the day, and I took David Chackey, who's in Brisbane now, our Australian fellow, through an anterior resection, and we noted there was a solitary metastasis in the liver. And when he got over his rectum, we decided to operate on the liver. The scan showed, a couple more. But when I got in there, he had lots of secondaries on the right side and lots of secondaries on the left side. But he had a Duke's A carcinoma, and I was so cross about it that without thinking, I took them all out. And of course, you weren't supposed to take out more than one. You weren't supposed to take out them on both sides. And there I was going, oh, looks like I've broken all the rules here, taken all. And then a year later, he recurred, and I was so cross about this, and this Duke's A carcinoma had caused such carnage. I took him back. I phoned my friend Johanna Shaler in Germany. I said, can we reoperate on the liver? He said, well, we just started doing that. Don't see why not. So we did, and took out 2 more. And you lived for another 28 years. And so he taught me a lot very early on. And I remember at the Millennium giving a lecture at the ASGBI, and a professor of surgery, who shall remain nameless, bless him, criticized me for daring to suggest that taking out bilateral metastases was an acceptable way forward. Yeah. And he was very critical. And I said, well, look, this is what the data shows. And actually, since then, every big unit, whether it's Sloan Kettering, MD Anderson, Paris, and so on, we've all shown the same thing. As long as you take them out, it doesn't matter whether it's one side or both sides. And I think a lot of people still struggle with that concept. I don't blame them. Because let's face it, it's a very strange idea. But I think for me is if you can find them, take them out. And so we've come a long way. And if it wasn't for that one patient with a Duke's A carcinoma, I think we may not have made such progress so rapidly.
We always envy the fact now that you can do really big operations on the liver, and we can do a small operation on the bowel, and the patients are set back much more. It's a really, if you do a liver resection carefully and safely, the patients recover, don't they, very quickly?
Yeah, well, I think the truth is, I'm quite terrified of bleeding. So an obsession for me was stopping bleeding from day one, and we found the recipe from Johanna Shaler, evolved that, and developed that purely because I couldn't bear bleeding. Really, and precision surgery.
Shouldn't have been a surgeon then, Mark.
Well, quite. I was only, I'm only, a little Welshman. So
Used to play rugby fairly tough. There was a lot of bleeding.
Yeah, well,
on the
very
rugby
tough
field.
on a lot of blood on the rugby field. That's all right. But actually, if you're very careful, you know, people recover from the liver very quickly.
Yeah,
and we've learned so much on how to fine tune that over the years.
And I think it's really important, isn't it, to look at the outcomes. And you've taken on what Bill did. You followed up your patients. You measure their survival, but also their quality of life. You can find a whole series of videos and links to our series of discussions around rectal cancer at this address. And if you have any suggestions what we might cover, please let us know. Thank you very much for joining us.